Okay, we are now live.
Welcome to today's webinar, Report Back from SGO, What's New in Cervical Cancer. I'm Aisha McClellan, I'm the Cervical Cancer Coordinator. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast and gynecologic cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, metastatic, ovarian, uterine, or cervical cancer alone. For more information about our upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders. All participants will be muted during the presentation. Once Dr. Hoppenot finishes presenting, we will begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that the speaker cannot give specific medical advice, so please keep your questions general in nature. Many questions were already submitted during the registration, so thank you to who has submitted questions. We will also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of your screen and selecting the subtitle option. Lastly, this webinar is being recorded. In a few weeks, we'll share the recording with all of the registrants and add it to our website. Now, I'd like to hand it over to Dr. Hoppenot to introduce herself.
Hi, everyone. I'm Dr. Claire Hoppenot. I am a gynecologic oncologist. I work in Houston, Texas with Baylor College of Medicine. I was initially trained in Chicago at Northwestern and then University of Chicago, and now I've been in Houston for the past about 6 years. And I specialize in gynecologic cancers and then also ethics and communication as well. Let me share my slides. Which I had opened a second ago. And today I want to thank Cher for inviting me to talk about the SGO updates in cervical cancer research. It has been an exciting few years for cervical cancer research. I have no conflicts of interest regarding this topic. Some of the hot topics to talk about, there are some big trials that just came out over the past year or two. Immunotherapy is very highly featured throughout all of the studies in cervical cancer. Antibody drug conjugates were a really big deal last year, and I feel like less so this year, but still a big deal in terms of treating patients and did come up a little bit. And then something we always work very closely with our radiation oncologists. So there were some changes and evaluations of our radiation treatments. So those are sort of the big things that I will talk about. Let me see if I can get the time open on here. Okay. So cervical cancer in general, I just wanted to get a baseline of sort of what our current treatments are so that when we talk about some trials that evaluate them, we have a baseline of what, how we generally think about cervical cancer. Almost all are HPV related. They and their precursor lesions, which is dysplasia, are detected by pap smears. Very early disease can be treated with surgery, and that is often a radical hysterectomy, lymph node evaluation, and sentinel node evaluation. Some recent studies have suggested that a simple hysterectomy is also adequate for very, very early disease. And then after, and here on the side, you can see this is what we are seeing in the body on the laparoscope. And then when we turn on the near infrared light after we've injected our dye into the cervix, you can see that the lymph nodes and the channels between them are lighting up. And this is how we can find a sentinel lymph node to remove. After the surgery, some patients require some radiation afterwards, and most patients do not. And our goal is to be able to detect who does and who does not need radiation. Unfortunately, what I see most often is these locally advanced cancers. So women who have not had pap smears, who have not had an early detection, and who are coming in because of symptoms, which is usually a sign that the cancer is more advanced. These are cancers that are over 2 to 4 centimeters in size, so about the size of a plum, or larger, involving the sides of the uterus and the parametria, or involving the lymph nodes. And usually these are treated with a combination of chemotherapy and radiation. This has been the protocol since the early 2000s. We do daily external radiation for 25 days and then weekly cisplatin chemotherapy treatments. And you can see here, I put an example of the linear accelerator machine that treats the cervical cancer. And then there are 3 doses of internal radiation. And you can see it's this device here that goes through the cervix and next to the cervix and gives the radiation treatments directly to the cervix. We expect with this the 5-year progression-free survival to be anywhere between 50 to 80%, depending on our studies. And most women can be cured with this. But obviously we'd rather have it be even higher than 80 at or higher than 80% if we can. For metastatic or recurrent cervical cancers, the treatment is with chemotherapy and immunotherapy. Over the past few years, immunotherapy has taken a larger and larger role. The immunotherapies that we use are usually PD-1 or PD-L1 inhibitors. The chemotherapy attacks the cancer itself and goes for the quickly replicating cells in the nucleus. The immunotherapy, I usually tell my patients, they help the immune system see the cancer and be able to attack the cancer directly. And so it's not that the immunotherapy is attacking the cancer, but it's getting your immune system to see the cancer. So it's keeping the cancer from being hidden from the immune system. So when I talk about immunotherapy, that will be what I talk about. So the first study that I wanted to talk about was the Phoenix 1 study. This was a study looking at early cervical cancers who were getting surgery and a lymph node dissection. And the question was whether we should consider removing all the pelvic lymph nodes instead of just that sentinel lymph node. So we have studies showing that the sentinel lymph node is very well representative of the lymph nodes, of the rest of the lymph nodes, so that if it's negative, 98% of the time, all the lymph nodes are going to be negative. But is that good enough? And should we be, if it's positive, will having removed the other lymph nodes be helpful or not? So they compared women, everybody got a sentinel lymph node first. During the surgery, the pathologist took a look at the lymph nodes. If it was negative, they went ahead with the surgery, which was the radical hysterectomy, and then either they removed all the pelvic lymph nodes or they didn't. And this would be the standard of care right now. We do not remove all the lymph nodes. And then they looked at the outcomes from there, and they found no difference. So they found overall that whether we remove all the lymph nodes or just the sentinel lymph nodes, the disease-free survival and the overall survival are basically the same. And so it does not seem to make a big difference. And so generally we would recommend staying with the standard of care, which is just doing the sentinel lymph nodes. Looking still at these early cervical cancers, GOG 263 looked at patients who had high risk factors after surgery. And so they were ones who were getting surgery followed by radiation. In those cases, generally patients are getting radiation without chemotherapy. But we do have a standard protocol for adding chemotherapy for those that are getting this as definitive treatments, the one who did not get surgery beforehand. And so the question was, if we add chemotherapy, can we make things better for these patients who are higher risk to begin with? And so again, they looked at early cervical cancers from stage 1 to 2A who'd had a radical hysterectomy and lymph node resection. They all had to have negative lymph nodes, but they had to have some intermediate risk factors such as the size, the lymphovascular space invasion, and how deeply it's invading into the cervix. And again, when they looked at it, they didn't see a difference. So overall, whether patients got chemotherapy or not, it was not superior to get chemotherapy. And so again, we can stay with our standard of care, which has been just giving radiation. And that's important because we don't want to overtreat. We certainly don't want to undertreat. We want everyone um, to do well, but we don't want to overtreat either because we know that there are side effects of all of our treatments. And they actually did look at the side effects. So they looked at patient-reported outcomes, and you can see that, not surprisingly, it was harder to get chemotherapy with radiation rather than radiation alone. but by the time you get to about 36 weeks, everyone is back to normal. So the good thing is that by adding chemotherapy, although the treatments themselves are a little bit more difficult, the it's not permanent, and it's something that patients can go back to having, equivalent back to normal life after the treatments. But even though there doesn't seem to be long-term side effects, there doesn't seem to be long-term benefit either. And so generally we are going to stay with just radiation after surgery for these patients who have had surgery with intermediate risk factors of their cervical cancer. One of the big talks at SGO, but that was also a big talk sort of, amongst all GYN oncologists over the past few years, over the past year or so actually, has been Keynote A18 and Interlace. And these are looking at those locally advanced cervical cancers. So the one where the tumor is too big, where surgery is not going to be the best treatment, and the best treatment is actually a combination of cisplatin with radiation, which is both the external and the internal treatments. And like I mentioned, the success rate is about 50 to 80%, depending on the study and depending on the patient, but we would like that to be better. And so we're looking at other things that we can add, with immunotherapy being such an important player right now in cervical cancer. One of the things that we were looking at was adding immunotherapy during the radiation. So the radiation already, like I mentioned, patients are getting cisplatin once a week. And then can we add the immunotherapy every 3 weeks on top of the cisplatin? One, is it going to be well tolerated? And two, is it going to help keep the cancer away? And then with the immunotherapy, it's something that we tend to continue afterwards for a couple years as well. So that was A18. Interlace looked at adding chemotherapy, so full dose weekly chemotherapy for 6 weeks before doing the cisplatin with the radiation. There had been a study, the Outback study, that looked at adding chemotherapy after chemoradiation and seeing if it could be just for high-risk patients, and they didn't show any difference. But the theory is that giving sort of this weekly repetitive dose before radiation, when the cancer is more sensitive to the chemo, may work better to get the cancer to shrink and then treat everything else with the radiation and the cisplatin. I'm going to start with A18. These were stage 1B2 to 2B node positive disease. So now we would call them stage 3 disease, or 3 to 4A from the FIGO 2014 staging. And they were randomized either to cisplatin, so our usual chemoradiation with immunotherapy, or just the usual chemoradiation with a placebo. And then the pembrolizumab, the immunotherapy, was continued for 15 cycles for 2 years afterwards, or the placebo. And their primary endpoint was progression-free survival. And they did find a difference. So you can see that the hazard ratio is 0.68. So it came out to about a 10% improvement in 5-year or in 2-year progression-free survival. And what was presented here was the overall survival, which was new and which was also improved with the immunotherapy. So we weren't necessarily causing, mortality or morbidity from our immunotherapy treatments as well. There are certainly different side effects. Immunotherapy, because it revs up the immune system, the side effects tend to be immune mediated, so autoimmune changes. Most of these are sort of what I call the itises. Most commonly is going to be a colitis causing diarrhea, or a thyroiditis, a dermatitis causing a rash, pneumonitis causing a cough. And so they did see that there were more immune-mediated side effects with the pembrolizumab, not surprisingly. More than grade 3 was about 5% with the pembrolizumab, and there was one patient who died of an immune-mediated gastritis. Their radiation characteristics were otherwise the same between the two. So overall, the 36 months overall survival went from 74% to 82%, which is a significant change. I think both statistically for sure, but I think also clinically, of at least 8% improved survival at 36 months, with understandably a different side effect profile of having to watch out for these immune-mediated side effects as well. Interlace is the other trial looking at very similar patients. These were a little bit earlier stage patients, so they did include some of the stage 1 and 2s without positive lymph nodes that were not included in the A18. And these were the patients that had the induction chemotherapy. It was carboplatin and paclitaxel dosed for weekly doses every 6 weeks, followed by the standard chemoradiation versus going straight to the standard chemoradiation. And you can see again that we have a hazard ratio of about 0.65 or 0.60, both in progression-free survival and in overall survival. And so chemotherapy prior to chemoradiation also improved the survival. And so the big question now is which one do we choose and which one makes the most sense? Like I mentioned, Interlace had some earlier stage patients. And so I know that for some patients, I've had insurances push back and not actually let me give A18 for some of the early stage patients. And so then we go to Interlace. I do think that most people seem to be gravitating towards A18 and adding the immunotherapy along with the maintenance. But there are some people who are more likely to have some immune mediated side effects, and so would then be considered for the Interlace trial instead. So that is still sort of a question that we take on a patient by patient basis, talk to the patients about some of the side effects as well, and then give our recommendation. But I am finding that a lot of people are gravitating towards this A18 just because immunotherapy has been so promising for so many disease sites. There are some studies looking at radiation techniques as well. So there's ongoing studies looking at IMRT, which is intensity modulated radiation therapy. The image-guided techniques, basically, they are avoiding giving large doses to surrounding organs, but they wanted to make sure it wouldn't compromise outcomes. So you can see here, it ends up being very detailed with exactly what dose goes to the tumor and the lymph nodes, in this case, the inguinal nodes. And then you can see it sort of having less and less as it's getting further away from these spots where we really wanted the high doses. And you can see that the toxicity has decreased over time with the IMRT. So both the cumulative incidence of toxicity of more than grade 2 and more than grade 3, and then any late toxicity of more than grade 2 as well. And late toxicities are important because our goal is to cure these patients. And so late toxicities can hopefully be there for a long time. And so ideally, we would not have any of them. And so this was for the external beam portion that the IMRT seems to have equivalent outcomes and to decrease toxicity and long-term toxicity to the intestines, to the bladder in general. They also looked at brachytherapy. So brachytherapy is actually can be very difficult to do. You have to be able to do a pelvic exam to place these instruments inside the vagina. Not all radiation oncologists are comfortable doing it. It's not available everywhere, and it can be difficult for patients to tolerate. They did a study looking at whether brachytherapy was still necessary or could they use some of these more fancy sort of IMRT type or SBRT, which is a very focal treatment on the cervix to help make up for it for places and people who weren't comfortable giving it. And they found that it actually brachytherapy does make a big difference. And so we do need to be having these patients go to centralized locations where they can get their brachytherapy treatments to have the best possible outcomes. And meanwhile, the brachytherapy has improved. It used to be that we would keep patients immobilized for 80 hours, so for multiple days in bed in the hospital with the treatments inside. Now we have this high dose rate where the patients will come in for a few treatments, usually as an outpatient. And again, trying to control so that we don't have as many side effects for these patients that we're trying to cure and have a long life ahead of them. So in terms of conclusions for radiation, there are more conformal radiations with IMRT and SBRT. So trying to really focus the radiation on the cancer with much less to the surrounding organs to help avoid side effects. But these are not a replacement for the internal brachytherapy treatments that do seem to improve our cancer-related outcomes. There were multiple other smaller studies on metastatic cervical cancers. Immunotherapy has been like I said, a very big deal that we're adding to our treatments, but we unfortunately have patients who progress despite being on immunotherapy. And so there were some studies looking at if we give immunotherapy again, um, can can that help improve? And these are small studies that would need, bigger studies to support them. But it does seem that this one immunotherapy agent, the cadonilimab, did seem to still have a response for many patients, even if they had progressed on a prior immunotherapy. There was another study looking at zimberelimab, which is another PD-1 inhibitor, plus lenvatinib, which is a tyrosine kinase inhibitor. It's a daily pill that we use a lot for endometrial cancer in combination with immunotherapy. So they are doing a similar combination to see, can we get that to work for cervical cancer in these metastatic cervical cancer patients. It was a phase 2 trial, so again, a small trial to look at tolerability, but they did find that there was some disease-free progression of more than 7 months. And for metastatic cervical cancer patients, that can be a long time. Sorry, let me make sure I don't have anything urgent. Okay, so in conclusion, this is an exciting time. There have been a lot of new treatments, a lot of new trials. Like I said, our previous treatment algorithms are from the early 2000s, so they are about 20 years old and they've been working okay, but we are adding things to them and seeing if we can get things better for a lot of patients. We have a lot of new options, and immunotherapy is a big one, and chemotherapy before radiation is another big one that we are looking at. We didn't see much about antibody drug conjugates such as tisotumab vedotin or Tivdak as much this year, but there are many different types of cancers. It did come up in other cancer types at SGO, and there is still a lot of that going on for cervical cancer as well. We're still working on how to define the role of immunotherapy in cervical cancer, and how to make sure that radiation, which is a cornerstone of treatments, is ha has the best possible, how to maximize its effect while minimizing its side effects as well. So I also was asked to make a key takeaway slide from the trials. So basically, the first couple trials showed that our standard of care of the sentinel lymph nodes and radiation after hysterectomy are still better than adding more lymph nodes or adding chemotherapy. So again, trying to make sure that we know if we're adding more, to make sure that more is better, because we know that more generally is more side effects, but we need to make sure that it's also better in terms of outcomes. And it seems like in these cases it was not. Looking at immunotherapy, that's had a growing role for the treatment and retreatment of cervical cancer. It initially started as a treatment in the metastatic or recurrent cancers, but it has been moving up to upfront with a curative intent for locally advanced cervical cancer. I mentioned the interlace trials with induction chemotherapy to help decrease recurrence for curative treatments of locally advanced cervical cancer, and then radiation treatments between IMRT, SBRT, and brachytherapy adjustments are improving in terms of managing side effects, and is still a cornerstone of our treatments. So hopefully that was helpful in terms of knowing sort of what is happening at SGO and what is in terms of what's coming up. I put my email address on here. I'm happy to answer any emails and answer any questions if you have any.
Thank you so much for that presentation. I didn't even realize I was at SGO and I didn't even realize there was so much going on. So it's very exciting. So we have now let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. Try to get through as many questions as possible in the remaining time. Okay, so since HPV is the main cause, how can the immune system be improved naturally?
Oh, that's a good question. I don't have a good answer for it. I wish I did. Um, so we know that there are some patients that have a higher risk of having the HPV persist, and that is related to some So people that are on immunosuppression, so I have a lot of patients that have had transplants and are on immunosuppression, and so the HPV definitely persists for that. Smokers, so anyone who smokes, yet another reason to stop smoking because that will help the immune system fight HPV. Um, and then I have a few other patients that have some just immunodeficiencies in general. But unfortunately, I don't have any good data to suggest any specific like supplements or I just recommend general well-being and general health, and knowing that there are some things that we can't fully control. And so we do what we can to be healthy, stay active, but yeah, everybody asks me like what supplement, all these things to help the HPV go away, and we just don't have any, I don't have any data to recommend anything.
Yeah, totally understand. What advice would you give a patient who's interested in joining a clinical trial, especially if they're nervous, unsure of where to start?
I think clinical trials are great. So I think that if you're thinking about a clinical trial, that can help you get some treatments that are sort of cutting edge. The thing about clinical trials is that they try to have equipoise, which means that, well, I would have you consider if you're at a point where you're thinking about a phase one, so trying a new medication that we don't know if it works yet, versus a phase three trial. So looking at the phase of the trial. Phase one is usually literally, we don't know if this works. We think it does. We have good reason to think that it does, but we haven't proven it yet. And we have great medications that come out of those trials and people that do very well on those medications. But there's no comparison. The phase three trials are ones that tend to have a comparison and to have equipoise. So both, as far as we know, both sides of the trial should be similar, and we're trying to see if something new can be better. And that tends to already have some data and some suggestions that the new medication is um, is working. And so I do think that usually the first and often second line treatments are pretty standard, and I would recommend doing those first, um, unless they are sort of incorporated in the clinical trial as one of the arms as equipoise. Um, but then after that, you can get access to a lot of very interesting medications through clinical trials. And so I would talk to your doctors in terms of what the expectations are, what phase trial it is. So whether there's what are the considerations, they aren't going to be able to tell you what are the chances this is going to work because that's what they're trying to answer. But they can give you a sense through the phase to see how much has this been studied so far and what are the expectations with it.
Great, thank you. Did any of the sessions focus on the role of survivors and advocates in shaping research priorities or treatment plans?
There were a lot of patient advocates at SGO this year. I don't remember if there were any specifically for cervical cancer, and they were involved in, I don't know that they were involved specifically in research. It was often in terms of patient outreach and patient outcomes. I do think it would be really interesting to have patients involved um, in research for sure, and in determining priorities for research. I don't, but I don't think that that was specifically discussed at SGO this year.
For patients who have already gone through treatment, what do these new updates really mean? Will they impact care now or more so long-term goals?
So if someone has gone through treatments already and is not, and has not been had signs of any cancer coming back, this should not influence you at all. But if, God forbid, there are signs that the cancer comes back, then all of this are things that are going to contribute to your treatment as well, because these are all things that could become relevant. But there's nothing like we don't go back and say, oh, you didn't get this same treatment that we thought you should have gotten, so we need to make up for it with something else. We can't do that, unfortunately, for better or worse. So you would still stay in the same sort of surveillance regimen that you're doing now and checking in with your doctors um and hopefully it never becomes relevant to you.
Were there any discussions about how to get newly approved treatments to patients faster, especially those on Medicaid or uninsured?
Um, I don't know that there were any discussions specifically about that. I know
Okay.
it's something that we are all sort of fighting for and fighting with on a daily basis. Um, I know that I work here at a safety net hospital, and so we have a lot of drug companies that give us free medications and that help support our patients. And so there's a very like strong working relationship between our pharmacists and the drug companies. And so I just wish that that could be replicated in more places, but um, I don't know that that was specifically brought up this year.
Have there been any updates to scanning guidelines? How long should you be scanned after having no evidence of disease?
That's a good question. I think different people do it differently. I don't routinely scan people unless I have some concern or the patient has some concern. And I know a lot of medical oncologists will scan like every 3 months or every 6 months for a few years. If that's something that you're worried about, I would talk to your doctor. It is a gray zone area. I don't think there's any firm recommendations. The rationale is that if we were to see cancer come back, we would want to find out when it's smaller rather than if it were to give it time to grow. But we don't have any data that that necessarily makes a big difference. So
Why do you think people are living longer with metastatic cervical cancer?
I think we have more better treatments. I think that immunotherapy is a few years old now, but that has made a huge difference. I can see it in my clinic. I have patients that, should have died 3 years ago that are just on immunotherapy and their disease is still there. They're, still struggling with a lot of things, but it's not growing and they're not having too many side effects from the treatments. So I do think that the new treatments, immunotherapy is a huge deal. Tisotumab vedotin is another new one that came out in the past few years. Um, and other different combinations, but I think it's that there are more treatments that we are able to give patients.
What are your thoughts on at-home cervical screening?
Ooh, I'm very excited for it.
Yeah.
Um, I think that we're actually looking at our ER to see if we can catch people coming through the emergency room again at this safety net hospital and having them swab themselves and take it because I think that so I'm excited for many things. It's tests for HPV. So it's not exactly like a pap smear. The pap smear tests for HPV and it tests for some precancerous cells. So it actually looks at the cells under the microscope and says, have there been any changes from the HPV? But we know that HPV is what causes almost all cervical cancers. So people that don't have HPV generally don't need to worry about it. With some caveats, I still recommend seeing your gynecologist on a yearly basis and getting regular pelvic exams, but it should be much, 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 much lower risk of cervical cancer. So this only tests for part of what the pap smear would test for, but it is the part that we're sort of all moving towards taking as the most important part of the pap smear. Everyone that has a positive HPV, though, will need follow-up testing. So that means having a doctor to go to, actually showing up to that visit, and then getting one, if not more, multiple pelvic exams and checks for that. So it allows a lot of people to avoid that completely, but it does mean that if you get that positive result, suddenly you're at home getting that positive result, and you need to figure out how to get into the system to get more testing. So that part makes me a little bit worried, and that I'm worried that that's going to be a big a big barrier in to getting patients what they need because just the positive test is not going to be helpful. And it doesn't mean you have cancer. It just means you have HPV and almost everyone will not have cancer. They may not even have dysplasia, but they are going to need to end up in the system and doing these regular checks with a gynecologist for the most part.
Do you think that more funding should be allocated for patient navigation?
I do. I think that that is something that we're struggling with at our hospital too, and at a lot of different places. I think that um, patient navigation, I think generally helping patients figure out where to go, where to be, how to make it work. And I think there's a lot of financial stress that comes with cancer treatments that I don't know how to help with. And so having people help with that. Um, I have a lot of people that struggle with transportation, things like that, that it's not really patient navigators, but it's other sort of help overall. But I think people end up with a lot of different appointments with radiation, with us, with sometimes even with a medical oncologist, and then for their scans. And so having someone that can help them sort of keep that organized and figure out what's what and where and why would be really helpful. My office staff is very good, and so we try to do that ourselves, and I try to stay on top of it so that patients and do a lot of written handouts in terms of what's coming up and why. But I've, there's always need for more support.
Okay, just a couple more. What is being done to reduce delays in diagnosis, especially for those who are dismissed at first?
The It's a hard question. The main thing, so things I was talking about, like the HPV test in the ER, are one of the things. These cervical cancers, the reason why they're much more rare in the US than in many parts of the world is because of our pap smear recommendations. So the
Mm.
pap smears detect them early. And so I think that people that are getting yearly pap smears, well, not yearly anymore, but as recommended, which can be, if normal, can be every 3 to 5 years, but if abnormal ends up being much more regular than that. Um, Ultimately having people do that with their primary care, their gynecologist, is going to be what's going to detect these cancers early. I suspect what the question is referring to is people that are coming in with pain and bleeding and don't get a pelvic exam, or are going to the ER and they're not doing pap smears or pelvic exams, or really detecting cancers that end up actually being bigger and more involved than what we would expect. Um, I do think that um, trying to encourage ERs to do pelvic exams when necessary, or to refer to hospitals, or to centers or to gynecologists as an outpatient to do that follow-up, I think is going to be important. Um, but otherwise, a lot of it is, yeah, just trying to get to that right person to do the physical exam that you need.
And I guess related to that, how are these updates helping to close the gap in care for the Black and Brown communities?
Um, There were a few studies, not so much in cervical cancer, but in other cancers, looking at specifically what the differences are, because we've clearly documented that there are differences in outcomes, but I don't know that we've exactly pinpointed why. Some of it I suspect is access, and especially in cervical cancer, like I said, unfortunately, it's people that are not getting pap smears, and people that are, disenfranchised in many ways, don't want to come see the doctor and get a pap smear, especially such an intimate exam can be really hard. And so, like I mentioned, our one of our um, students is doing this study looking at HPV tests in the ER. So people that are coming in for other reasons, who are trying to get, we're trying to say, okay, I have this easy test, we can check for cancer or risk for cancer, and then trying to get them into the clinics that they need to be in to follow up from there. Cervical cancer in particular, in in our clinic is like over 60% Latino, and then 20% Black. So it's very much um, the Black and Brown people, and we have a very high rate of cervical cancers, but a large part of that is because it's a safety net hospital, and because people are coming in only after they have this diagnosis and not coming in for the screening. So I do think that there would be a lot of room for outreach and getting people into clinics, or going out to people to get this screening done, so that we catch it early. rather than wait for it to be locally advanced.
Right. Last question. What is the most exciting thing you see in the future of cervical cancer?
I'm still hopeful for prevention. I have talked about pap smears a lot.
Yeah.
Um, but I think the immunotherapy has been the most exciting thing, over the past few years, and now adding it to our chemoradiation for patients, I believe will make a big difference. I haven't seen that yet because it's been less than a year since I've started it, and so I haven't seen, a difference in outcomes, but I'm very, very hopeful for that we can get more people cured and not having to worry about this again in the future.
Cheers to that.
Yep.
Thank you so much for your thoughtful and thorough answers to all these questions. Thank you to everyone who's joined us today. We will have a recording of this program available on our website in a few weeks. Please check SHARE's website for upcoming educational programs and support groups. Don't forget to follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be available in a follow-up email. All surveys are anonymous. Thank you so much again for your presentation. This concludes the webinar, and I hope everyone has a great day.
Thank you so much.
Thank you.